Hi, everybody. I'm Chantal Yashova,
And I'm Yuvar Abgin.
and we're presenting today on a trial of intensive blood pressure control in older patients with hypertension. So this is based on an article that was published in the New England Journal of Medicine in August of 2021. For some background, the appropriate target for systolic blood pressure to reduce cardiovascular risk in older patients with hypertension remains unclear at this time. In this multi-center randomized controlled trial, the authors assigned Chinese patients 60 to 80 years of age with hypertension to a systolic blood pressure target of 110 to less than 130 millimeters of mercury, which was the intensive treatment, or to a target of 130 to less than 150 millimeters of mercury, which was the standard treatment. So they were testing to see which target range would reduce their risk of cardiovascular events.
Okay, so the primary outcome was a composite of stroke, acute coronary syndrome, acute myocardial infarction, and hospitalization for unstable angina, acute decompensated heart failure, coronary revascularization, atrial fibrillation, or death from cardiovascular causes.
So the results of the 9,624 patients screened for eligibility, 8,511 were enrolled in the trial. Of those enrolled in the trial, 4,243 were randomly assigned to the intensive treatment group, and the rest of the 4,268 were assigned to the standard treatment group.
So at 1 year follow-up, the mean systolic blood pressure was 127.5 millimeter mercury in the intensive treatment group and 135.3 millimeters mercury in the standard treatment group. During a median follow-up period of 3.34 years, primary outcome events occurred in 147 patients, which is 3.5% in the intensive treatment group, and as compared with 196 patients, which makes up 4.6% in the standard treatment group, showing that the target group, the intensive group, did actually reach a lower systolic blood pressure and had lower primary outcomes that occurred at 3.34 years.
So the results for most of the individual components of the primary outcome also favored intensive treatment. So the hazard ratio for stroke was 0.67. The hazard ratio for acute coronary syndrome was 0.67. For acute decompensated heart failure, it was 0.27. For coronary revascularization, it was 0.69. And the hazard ratio for atrial fibrillation was 0.96 with a 95% confidence interval. And for death from cardiovascular causes, it was 0.72.
So the results for safety and renal outcomes did not differ significantly between the two groups, except for the incidence of hypotension, which was higher in the intensive treatment group. So you could conclude our presentation, Chantal.
So in conclusion, in older patients with hypertension, intensive treatment with a systolic blood pressure target of 110 to less than 130 millimeters of mercury resulted in a lower incidence of cardiovascular events when compared to the standard treatment with a target of 130 to less than 150 millimeters of mercury. So we can conclude from these results that the lower target range with a more intensive treatment clearly resulted in a lower incidence of any kinds of cardiovascular events. And it didn't have any higher other safety concerns. So this is a strong piece of evidence to show that a target of 110 to 130 millimeters of mercury is a more effective way in reducing the risk of cardiovascular events than a lot of the standard treatments, which have a target of 130 to 150 millimeters of mercury.
That was very well put. So you're essentially saying that going the intensive route can be more effective long term for the health of patients who are undergoing these routines. One thing I wanted to add is how in a medical environment, which is where I currently work, A lot of the times when I take in patients and grab their vitals and write down their blood pressures, very frequently I write down the blood pressures of patients who have a systolic blood pressure of for sure over 130. And whenever I take these charts back to the physician for the physician to go into the room, and I accompany the physician into the room, many times after speaking about why the chief complaint of why the patient has entered the care facility, we discuss how we can essentially change lifestyle habits and change lifestyle behaviors and practices to promote preventative medicine. And preventative medicine, although the word is preventative medicine, it does take initial action to instill preventative medicine, which is when the physician would recommend changing, again, affecting salt substitutions, which is from our previous presentation, into their diets to also affect lower blood pressure, get more sleep, do more cardiovascular exercise, and remain in a hypoxic state while exercising, essentially being out of breath for a long time. All these things to effectively reduce their blood pressure the next time they come in. And it's clearly evident here that doing these practices and following the recommendations of the physicians who know this knowledge based on evidence-based information can, in the long run, effectively protect the patient against long-term damage in their cardiovascular system and protect them against higher incidence or higher risk of stroke, hypertension, complications, and all those adverse outcomes that we listed.
You know, a lot of the times for patients who come in with a systolic blood pressure that's well over 150 millimeters of mercury, of course, the first thing you want to do is bring it below that 150 mark. But a lot of the times, there's a more significant decrease in a lot of these cardiovascular risks when the target is lowered to below 130 millimeters of mercury. So we really want to, if possible, implement those lifestyle changes that you mentioned, implement any medication that might be recommended by a physician to really get to the target of 110 to 130 to decrease that risk as much as possible.
Completely agree. And thank you for your attention, everybody who watched. And yeah.
Thank you.